starting March Madness this week. The ankle sprain is the most common injury in basketball. So we're going to share with you some new insights into ankle sprains that may surprise you. There's some really good clinical applications to some of this information. So um, uh, thank you for logging in. I think you'll find it worthwhile. My own interest in this comes from a lot of research and publications that I've done. This is the one I'm most proud of, where I was the only podiatrist on a panel of experts for the National Athletic Trainers Association, where we published a position statement on the management and prevention of ankle sprains in 2013. I have published other papers on my own that I'll refer to during the course of this webinar. And most of what I'm going to share is also encapsulated in my book. So I always promote my book, which is available via e-version or hard copy from springer.com. So really the message here is that we can do a much better job of managing ankle sprains. And I'm going to quickly show you why. But because we're talking about March Madness, it's really appropriate to share a human story about March Madness and the ankle sprain that kind of brings us right home. So we're going to take you back to the year 2022, and the Final Four is the first week of April. And in 2022, the final two teams are University of North Carolina playing Kansas. Unfortunately, UNC's one of their star players, Armando Bacot, injured his ankle, had an ankle sprain during the semifinal game against Duke. And there was speculation that he would not be able to play. And of course, this is the highlight of his collegiate career. And despite a severe ankle sprain, he is going to play in the final game against Kansas. And so here's Armando before the game, and this is during the game. Now, this was late in the fourth quarter. North Carolina led the game through most of the game through the first half by as much as 15 points. Kansas came back. The game is almost tied, and Armando is going to drive to the hoop, having suffered a previous right ankle sprain 48 hours ago. So watch his right ankle. Boom. And he goes down a pretty severe sprain. We're going to look at it again. And he goes out of the game, and North Carolina loses the game to Kansas. Why did he sprain his ankle after suffering a previous sprain 48 hours ago? We're going to explore all of the mechanisms that go into the recurrent ankle sprain in this webinar. It's the most common injury in sport. We've already stated that. But what is really important is we don't know how to manage this injury, because up to 50% of patients never recover from a first-time ankle sprain. An ankle sprain has the highest rate of reoccurrence compared to any other injury in sport, just like Armando Bacot. These are studies that document that. And what's really alarming is the rate of recurrence in young athletes. When we look at teenage athletes or even younger, not only is the ankle sprain the most common injury in sport, but this study showed that 98% of them suffer a recurrent sprain after the first year of the initial sprain, meaning these aren't getting properly treated at all. And this study, which is quoted most often, shows that at least 40% of individuals after a first-time ankle sprain go on to develop a syndrome, which we now call chronic ankle instability. Chronic ankle instability, this is the most up-to-date definition, is a condition characterized by repetitive sprains or simple perceptions of the ankle giving way. More importantly, ongoing symptoms of pain, weakness, reduced range of motion, and overall reduced bodily function. And these symptoms persist at least 1 year after the initial injury. Chronic ankle instability is a blend of perceptual, sensory motor, and structural deficiencies that contribute to this risk of re-injury and, as we're going to show you further, the development of post-traumatic osteoarthritis of the ankle. In the end, this is what we want to prevent, because once we develop post-traumatic osteoarthritis, the treatment options are not necessarily good. We used to think of chronic ankle instability to be really divided into two groups of patients: those who have failed to heal the initial ligament injury, and another group who have a deficit in neuromuscular control. We now know that there is no distinct separation between these two groups. Chronic ankle instability really reflects a blending of many contributing factors. The tearing of ligaments or the spraining of ligaments in the ankle does lead to mechanical instability and laxity of the ankle, but it also contributes to this whole mechanism of loss of proprioception and loss of central processing, which is really the focus of this particular webinar. Mechanical instability is pretty straightforward and fairly easy to detect in the ankle. The anterior drawer test for disruption of the anterior talofibular ligament is almost 100% sensitive for detecting ligamentous disruption, and this has been confirmed with MRI studies. But as we now know from many, many papers, hundreds of papers on chronic ankle instability, that laxity of the ankle up here is only one of many, many factors, both on the motor side and the sensory side of stability of the ankle joint, which ultimately may lead to chronic ankle instability, or if it's treated properly, push this patient into what we call a coper category, meaning they fully recover from the ankle sprain. The concept of proprioception, at least when I was in school and early in my career, focused on the feedback mechanism from sensory organs in the muscles and on the plantar surface of the foot and the mechanoreceptors of the ankle joint. And we were really focused on whether information was getting from the foot and the ankle and the leg back to the brain. And we focused on trying to restore sensation here for preventing chronic ankle instability. In the last 20 years, we've learned that that's really a small part of the problem. We've now learned that it's this feed forward side of the loop that is diminished, if not totally blocked, in chronic ankle instability. And it's this feed forward muscular activation that begins in the brain itself, in the primary motor cortex and in the cerebellum. So this loss of postural control over the ankle relies on feedback and feed forward. And it's really both sides of this loop that we need to look at in order to properly treat these athletes and prevent chronic ankle instability. To understand the loss of feed forward mechanism, I want to share with you a series of videos and episodes on the late, great Kobe Bryant, because this video of a severe ankle sprain that he suffered in 2011 was really the result of multiple ankle sprains that he suffered 15 years prior. He had a history of recurrent ankle sprains on his left ankle, and despite all of the treatment options available to a high-end athlete for a professional basketball team, he still had chronic ankle instability. This is a game at the end of the season in 2011 against the Dallas Mavericks. And Kobe Bryant goes up for a jump shot and without any contact suffers a severe left ankle injury, left ankle sprain. And the mechanism of this injury demonstrates his loss of proprioception, and his loss of muscular activation.
I don't think he did. I mean, we haven't gotten a clear shot yet, but
Here's his landing.
Left ankle.
oh,
Left ankle. Ouch.
I do not have the stomach to witness such thing.
You're right, Mark.
Yeah, I don't
So
think he did. I mean,
what we're going to look at here is a couple of things. Is as he's in space, he keeps his right ankle dorsiflexed and everted because he knows how to activate those muscles. But his left ankle is helplessly hanging in space. It's almost like a hemiparesis on the left side. And as he lands, that ankle is plantar flexed and inverted relative to the supportive surface, and it passively drops into a severe inversion ankle sprain. So if we compare the attitude of the two ankles in space, we can see the marked difference on the left side because he's not properly activating a protective muscular activation to dorsiflex and evert that left foot and ankle. And helplessly, it comes to the ground and goes into marked not only inversion, but this really demonstrates the transverse plane mechanism of most ankle sprains, where the foot internally rotates on the leg or the leg externally rotates on the ankle. So it's not just frontal plane inversion, it's transverse plane internal rotation. This is all due to a loss of the anterior talofibular ligament and the loss of muscular activation from his brain, not from his ankle.
Left ankle. Ouch.
I do not have the stomach.
He played the next night in the next game. He did not miss any games during that series. A month later, he re-injures the left ankle, not surprising, because he never let it heal properly. And he suffered a fairly severe ankle sprain in March 2013, which was actually the beginning of the NBA playoffs. This article in April 2025, in 2011, he suffered another ankle sprain in Game 4 of the first round of the NBA playoffs against the New Orleans Hornets. And he refused any imaging studies of his ankle and insisted on going out and continuing to play after he had suffered 2 previous ankle sprains. The one I showed you on video, he said was the scariest ankle sprain of his 15-year career. None of these sprains did he rest his ankle. 2 weeks after that article, Kobe Bryant suffered a left tendo-Achilles rupture, the same foot and ankle. This tendo-Achilles rupture most likely was a result of improper muscular activation and splinting of his entire left lower extremity because he was suffering from a loss of active feed-forward mechanism of his entire left lower extremity musculature from all of his multiple ankle sprains. The problem with Kobe Bryant and many athletes with chronic ankle instability is this feed-forward side of the loop, where they have an inability to process incoming information about proprioception and then properly activate the sequence of firing of muscles to protect his ankle upon impact. The processing of this information is at multiple levels of the central nervous system, both in the prefrontal cortex, the parietal lobe of the cortex, as well as the cerebellum of the brain. We now know that chronic ankle instability is associated with and leads to now documented changes in the brain and the central nervous system. There is now evidence for a central mediated mechanism for chronic ankle instability. We were questioning this before we had imaging studies to document it, because we saw evidence of delayed muscular reaction in patients with chronic ankle instability. And curiously, we noticed that both legs became weak after a unilateral ankle sprain. We saw this after anterior cruciate ligament rupture, where both quadriceps muscles would become weak. We found altered balance and altered excitability patterns in certain muscles in both right and left extremities after unilateral ankle sprain. And we saw inability of the athlete to carry out functional activities like landing from a jump, running and cutting. All of this suggested that there was something going on with central processing and proper muscular activation. These are the references that documented these diminished motor tasks in patients with chronic ankle instability. And then we began to see changes in the brain that helped explain why these changes occurred. Some of these studies were performed as early as 2006. And as I'm going to show you, there's been a host of studies, a rather large boom of interest in this just in the last 5 years. How can we image the brain or test the brain to determine that there's change of function in patients after anterior cruciate ligament or chronic ankle sprain or chronic ankle instability? We can use tomography, functional MRI, electroencephalography, and even transcranial magnetic stimulation. I'm going to show you some studies that use various techniques such as these. The most popular today is functional MRI. This is a newer MRI technique that's actually able to measure regional blood flow and metabolic changes in the brain. And these changes give direct relevance to neural activity and firing level. This is a non-invasive but very sensitive test, giving spatial resolution and temporal resolution of brain activity. This study done in 2017 showed that certain areas of the brain that are associated with activating the peroneus longus muscle had diminished function in patients with chronic ankle instability. Several other studies using MRI have documented decreased brain activity in the areas that activate motor neurons of the peroneus longus, tibialis anterior, soleus, and gastrocnemius. It's those areas of the brain that get compromised with multiple ankle sprains, which may have in fact rendered Kobe Bryant susceptible to a tendo-Achilles rupture because of failure to properly activate the gastrocnemius or perhaps the antagonist muscle groups in the tibialis anterior. This is a technique using near-infrared functional imaging in studying patients with chronic ankle instability. And if we compare on the left, these are patients in a control group. And let's just look at this area of the brain compared to patients with chronic ankle instability. We see diminished activity. It's the same in all of these regions of the brain where they detected significant differences in brain activation in the cerebral cortex in patients with chronic ankle instability. This phenomenon is known in physiology and neuroscience as a phenomenon known as neuroplasticity. Neuroplasticity is the ability of the brain to adapt and change based on internal and external stimuli. What it really means is that when the brain is not receiving input from distal proprioceptors, it undergoes changes, looking for activity or modifying itself to try to compensate. This is a fascinating new area of understanding, not just with chronic ankle sprains, but we see this after anterior cruciate ligament injury, and we've long seen it after patients suffer hearing loss. It's well known that hearing loss diminishes input to the brain, and the brain undergoes significant changes without sensory input. As a result, patients with hearing loss are highly susceptible to early onset of dementia. Neuroplasticity, and specific to the ankle sprain, seems to be linked to the lack of input from mechanoreceptors distally in the injured ankle joint. But it also seems to be affected by psychological states, the fear of re-injury, and the overall effects of pain and the emotional response of pain manifests in the cerebral cortex, as do other emotional responses. So we see lack of proprioceptive input from torn ligaments, but we also see that pain modifies other proprioceptors, including muscle spindles, and this leads to cortical changes in the central nervous system. Swelling seems to inhibit the distal proprioceptors, and the loss of joint motion seems to affect joint and muscle proprioceptors. So we look at that and we realize that when we treat an ankle sprain, all of these things are within our control as clinicians. Because if we allow the patient to continue to suffer pain, swelling, and loss of joint motion, we now know from research that this is bound to cause neuroplasticity in the brain and set up the syndrome of chronic ankle instability. This is an MRI study showing that patients with chronic ankle instability actually have reduced gray matter in the cerebral cortex. This is absolute evidence of atrophy of the brain after a peripheral ankle sprain. The bar graph here shows patients with chronic ankle instability are in green and healthy controls are in red. And in these 6 regions of the brain, there's definite evidence of atrophy in those patients with chronic ankle instability. That's pretty eye-opening, if not alarming. Another study performed by Rosen, not using MRI, but using a technique called functional near-infrared spectroscopy, which demonstrates reduced brain activity in patients with chronic ankle instability. Not only reduced activity, but abnormal waves in patients with chronic ankle instability, behaving much more or much differently than healthy controls. Rosen also did psychological studies on patients with chronic ankle instability and found that they actually suffered from deficits in memory and attention. Again, reaffirming this rather alarming connection to the brain and changes in brain function after multiple ankle sprains. The resting state MRI appears to be the most popular imaging technique used now in research for chronic ankle instability. It measures intrinsic blood oxygen level in the brain and gives indirect measurement of neural function and allows researchers to compare healthy subjects with chronic ankle instability in various areas of both the cerebral cortex and the cerebellum. This is using that technique. This is a study looking at the thickness of the cerebral cortex and found that patients with chronic ankle instability actually had a thinner gray matter area in certain areas of the supplementary motor activity area of the cerebral cortex. So the sensory motor area seems to be definitely affected when patients suffer a peripheral or distal ankle sprain. And it seems to be affected by loss of sensory input and then resultant loss of motor activation. Another study looking this time not at the cerebral cortex, but the cerebellum. In the cerebellum, reduced gray matter in patients with chronic ankle instability. Specifically, in this area of the cerebral or the cerebellum is a key role in integrating afferent incoming information for proprioception and joint position sense to coordinate balance and muscular activation. So this cerebellar vermis is definitely affected in chronic ankle sprain, and it plays a vital role in integrating proprioceptive input, maintaining balance and muscle activity. Here is that study showing reduced activity in that cerebellar vermis in patients with chronic ankle instability. Another study showing neuroplasticity in the gray matter of the brain in patients with chronic ankle instability opposed to healthy controls. So all of these papers were published in the last 5 years and are giving us alarming insight into what happens to our brain after we suffer a peripheral joint injury, whether it's the ankle or the knee. So you would ask, well, what can we do about this? Well, rehabilitation specialists are looking at this research and modifying rehabilitation programs to try to reverse the literal brain damage that we see, to try to reconnect neurons and restore normal brain activity using methods that we've learned with motor learning, with learning skills, as particularly complex skills, and studying how the brain adapts and learns complicated activities. This is an interesting article using the neuroplastic adaptation model for ACL rehabilitation. This was just published in 2021. We're just now learning how to modify these programs to try to incorporate the brain into the rehab program. It really incorporates methods of motor learning, where we not only teach the brain how to respond to sensory stimulus, but we incorporate brain activities such as decision making, reaction time, and letting the brain function properly despite distraction, which is what happens in sport. And so these rehab programs start out with very low complexity exercises for decision making, reaction time, and employing distraction, but then combining decision making with distraction, etc., to very high complexity rehab protocols and tasks and exercises, where we combine all of these together to try to bring the brain into the rehab program, as well as everything that we used to do distally around the ankle. In the end, we're trying to prevent the sequela that occurs with chronic ankle instability, and that is patients who suffer ligamentous injury will develop post-traumatic osteoarthritis. As much as 50% of them will go on and develop osteoarthritis later in life. Patients who get arthritis in their ankle do not get it from wear and tear. They only get it after trauma. Unlike the knee and the hip, the ankle is a very robust, sturdy, durable joint. But after an ankle sprain or ankle fracture, it is very vulnerable to arthritis. 90% of patients who have arthritis of their ankle got it from trauma. Whether it was a severe ankle sprain or a fracture, that's how they get it. In the hip, trauma is not linked to arthritis. And in the knee, it's only 10 to 12% of the time. But in the ankle, at least 80% of the time, it's linked to trauma. And what that means is we're not managing this trauma properly. We should manage this properly because getting arthritis in the ankle is totally preventable. 50% of patients with ankle joint post-traumatic osteoarthritis have a history of ligamentous injury from a single ankle sprain, usually when they were a child or a teenager. End-stage osteoarthritis takes approximately 50 years to develop in the average human. This study says it can occur in as soon as 26 years after a single severe lateral ankle sprain. The problem is very few clinicians have noticed these insights gained from this research, and we continue to practice the same protocols and decision-making with ankle sprains that we did 50 years ago when we said, it's just a sprain, get out and play tomorrow. But let's look at how we're treating ankle sprains in young athletes, just to verify what I just said. This is a study done 3 to 15 years following an initial ankle sprain in kids, following them 15 years later. These are kids under the age of 12 who suffered as a first-time ankle sprain. We find that 15 years later, the majority of them are suffering significant health-related quality of life disabilities, whether it's recurrent sprains, fear of a recurrent sprain, or in many cases, they stop playing sports altogether. It's really a call to action for us to properly prevent and treat these sprains. In 2016, a group of researchers, some of whom I worked with our paper with the athletic trainers, published a consensus statement on this exact topic. And they were really pointing out that we have to focus on young patients, adolescents, and young adults, and realizing the effect that ankle sprains has on their quality of life and their propensity to develop arthritis later. We are really mistreating these patients and putting them back to sport way too soon. Let's start with the realization that the ankle ligaments are no different than the anterior cruciate ligaments or other ligaments of the knee. They take just as long to heal as the ACL, but up till now, most clinicians fail to recognize that. Many of us have been taught the biology of tissue healing, the biology of bone healing, and we know that after a severe ligamentous injury, it takes up to 12 months for final maturation and remodeling of the ligaments to retain or restore original strength. It's a long 12-month process going through 4 phases. Yet we seem to ignore the biology when we make clinical decisions about treating this. Research has shown using animal models that it takes up to 12 months in the ankle for ankle ligaments to retain their full strength. 12 months. Therefore, how long should we protect the ankle after a grade 2 or grade 3 ankle sprain where there's documented evidence of ligament tearing? We should keep them protected at least for 6 months because the ligaments have not fully restored their functional strength. But in real life, that's not what we do. There are many ongoing studies looking at how quickly we return athletes to sport. Way back in 2002 in the NC2A, we were returning athletes to sport 6 weeks after a grade 3 ankle sprain and only 12 days after a grade 2 ankle sprain when they're barely into the second phase of ligamentous healing. This I just took off the internet a couple of weeks ago. Professional basketball player suffered a significant probable grade 2 ankle sprain, and they say sadly he's going to have to miss 10 to 14 days of play. This is only halfway into the phase 2 of ligament repair and well before the ligament has even had a chance to restore functional strength. A study in 2014 of high school athletes, a large group of high school athletes over a season, in the 2007 to 2008 season, where they studied 479,000 athlete exposures in high school athletes. 204 ankle sprains occurred during that season. And what was alarming is that of those athletes, the average time of return to play was 1 to 3 days. 1 to 3 days they were sent back to play where no effective biologic repair had occurred in their ankle ligaments. No wonder they go on 50% of the time and develop chronic ankle instability, and then 50% of them go on and develop post-traumatic osteoarthritis. So how can we do a better job? Well, we're seeing revision and position papers, not just from the athletic trainers, but from the physical therapists who are finally integrating the knowledge we've gained about the central nervous system and the knowledge of chronic ankle instability into better treating the first-time lateral ankle sprain. This is an excellent position paper published in 2021. It was published in the Journal of Orthopedic Sports Physical Therapy, and the lead author is Rob Roy Martin, who's a PhD physical therapist. To cut to the chase, they basically divide patients into those who suffer a first-time ankle sprain and those who have already suffered multiple ankle sprains and are now into this syndrome called chronic ankle instability. And we actually treat them the same. Most of the rehabilitation protocols, whether it's a first-time sprain or a recurrent sprain, are actually the same. If we compare these two boxes, and this is a whole lecture in itself, but basically, we're basically going to talk about introducing early on therapeutic exercise, both in the clinic at home. We're going to introduce manual therapy with joint mobilization, specifically talar or talus mobilization to restore dorsiflexion. We're going to perform new modalities, including laser, which has been shown to be helpful, shortwave diathermy. We're going to reduce pain with non-steroidal anti-inflammatory medications because we now know that pain and swelling are the primary instigators of loss of proprioceptive and brain damage. And we're going to address the psychology of the ankle sprain. We're going to address the fear of recurrent sprains and the emotional impact of the ankle sprain on the cerebral cortex. Keep in mind that neuroplasticity develops after the initial ankle sprain, and our goal as clinicians is to change and restore feedback from the ankle to the brain as soon as possible to prevent neuroplasticity from occurring in the first place. So we know that the patient has lost proprioceptive input from ligament mechanoreceptors, but there's ways we can send proprioceptive input back to the brain while the ligaments are healing. We now know that pain is a big problem and that we have to do whatever we can to minimize or reduce pain immediately after the initial ankle sprain. Swelling has a bigger input on the brain than what we thought previously. We have to reduce swelling because swelling inhibits proprioceptors. Loss of joint motion reduces input to the brain via not only joint proprioceptors, but the muscles. If we don't get the ankle moving early, we don't get the muscles stimulated around the ankle, and we lose input to the brain, and we start to induce neuroplasticity. So this old eponym of PRICE, protection, rest, ice, compression, elevation, is more meaningful today than it ever was because it specifically addresses some of those input deficits that leads to neuroplasticity. Pain. I think we really need to listen to the athlete and go overboard in reducing pain, even using analgesics, whether it's non-steroidal and in some rare cases, even opiate type analgesics, only to stop this vicious cycle of pain reducing proprioception. Ice, of course, remains a great remedy for reducing pain initially after the ankle sprain. Swelling, I think we overlook the role of swelling. And now from these brain studies, we realize how important swelling is in contributing to loss of proprioception. We have to get rid of swelling. Compression sleeves and compression socks are readily available today, and the circumferential compression that we can get from these compression sleeves and the fact that the athlete can wear them 24 hours a day is mandatory during the entire recovery of the ankle sprain. The loss of range of motion. We used to think that we had to protect the ankle and put them on crutches, and there's some evidence that protecting the ankle is important in terms of ligament healing, but the total loss of range of motion absolutely leads to a blockage of proprioceptive input to the brain. We have to get that ankle joint moving off weight bearing in a very controlled environment, usually under the supervision of a skilled physical therapist, to give proprioceptive input back to the brain. And finally, what has gained great recognition is arthrokinematic restrictions. The fact that after an ankle sprain, these joints shift out of alignment. The talus shifts, the calcaneus shifts, and the midfoot joint shift due to the violence of the ankle sprain. And now today's skilled therapists and rehab specialists use joint mobilization and manipulation to literally move these bones back to place. Left out of place, we lose proprioception. And this factor alone contributes to neuroplasticity in the brain. So the anterior to posterior glide of the talus must be restored with joint mobilization. We must reduce anterior displacement of the talus on the tibia. And we find that the distal fibula is often displaced and has to be moved posteriorly with manipulation or mobilization. We should also focus on restricted motion at the subtalar, mid-tarsal, and even the tarso-metatarsal joints. So this is a whole new approach to recovery from an ankle sprain that absolutely addresses some of the deficiencies that lead to neuroplasticity. So restoring ankle joint dorsiflexion with joint mobilization and manipulation is critical. And so now we'll see these therapists doing fibular glide and talar glide, posterior glide, and other maneuvers. And if your rehab specialists that you work with are not employing these techniques, then they're not really performing state-of-the-art rehab for ankle sprains as we do today. So I'm going to quickly, because I'm running out of time a little bit, I want to kind of bring this back to the Richie brace because we have found that not only is bracing critical during the recovery of the ankle sprain, but it's also critical in the return to sport. So there's a lot of evidence now that patients who suffer an ankle sprain should be placed in a brace when they return to sport for a period of at least 6 months, if not 9 months. And there's a mountain of evidence now showing that because these ligaments have not fully repaired until at least 9 months, that the athlete is going to need external support. And that's what's really missing in a lot of these rehab protocols is they're returning the patient to sport without a brace and often relying only on taping, which has been shown to be totally ineffective long-term and during a workout and during competition in protecting the ankle. We've learned from 25 years that the Richie brace seems to ideally address multiple factors of chronic ankle instability and loss of integrity of the anterior talofibular ligament, mainly because of the proprioceptive stimulus around the ankle and, more importantly, the contour of the foot plate to the proprioceptors on the plantar surface of the foot. We know that a properly contoured foot orthosis gives great input to the proprioceptors on the bottom of the foot to help patients with chronic ankle instability. I wrote a paper on this back in 2007 where I summarized 8 research studies documenting the effect of foot orthoses to improve proprioception and postural control. And these are just some of those papers. Amazing research showing how a simple foot orthotic greatly improves postural control and perineal reaction time. And so we think that foot orthoses alone help control lateral body sway and help activate musculature in the lower extremity. These researchers concluded that orthotics should be used after all acute ankle sprains to improve recovery with proper proprioceptive input and muscular activation. And so what we really believe is manifest with the Richie brace is combining the research we know from custom functional foot orthoses with the unrestricted motion of the ankle joint and customization of the ankle brace fit to the ankle. And so our casting protocol involves subtalar joint neutral, locking the mid-tarsal joint, and balancing the forefoot to the rear foot. And so we mark the malleoli so we can place the ankle joint hinge properly to allow unrestricted sagittal plane movement of the ankle during recovery of the ankle sprain, but restrict unwarranted internal and external rotation of the foot, and of course, restrict inversion and eversion of the ankle joint itself. So we place the ankle joint axis according to the patient's own anatomy at the tips of the malleoli. And in so doing, we customize the ankle joint axis for optimal performance of the athlete inside the shoe. And this goes forward whether we cast the patient for the Richie brace or do scanning. We balance the forefoot to the rear foot. We balance either forefoot varus or forefoot valgus to stabilize the subtalar joint and the mid-tarsal joint. And really try to stimulate these proprioceptors on the bottom of the foot, which enhances the overall effects of the ankle brace itself. If the brace is properly fitted to the foot and ankle, it'll properly fit into the shoe. And that's a big issue with athletes because of cleated footwear, where they don't want to inhibit shoe fit, and they certainly don't want to inhibit flexion of the ankle joint for sport. If they're going to go back to sport 3 to 4 weeks after a severe ankle sprain, they must be braced. And they resist being braced because they think they're going to lose performance. But if the brace is constructed properly, it will not inhibit performance. And we have placed our Richie brace on several high-level, both collegiate and NBA players who wear the brace in competition and do not see it affecting their performance. So that kind of wraps up that part of it, and I'm going to open it up to questions and answers. I kind of went through that quickly, but I just want to point out that this webinar is sponsored by all of the Richie Brace partners, which you can find on the Richie Brace website. These partners are Foot Orthotic Labs, who provide foot orthotics and the Richie Brace and provide you with any information you need for ordering the Richie Brace in terms of cost, billing, reimbursement with Medicare, et cetera. So I thank all of these lab partners who, again, are on the Richie Brace website. So with that, Sarah, I'm going to let you fire away with some questions. Hopefully we have some.
Yeah, actually, we don't have any yet.
We
Dr.
don't.
says hello, but and sorry, I will show my face here in just a second. I just have to, my computer is, I was walking around my house. So I am just getting myself, you went a little bit faster than I thought you did.
Yeah.
So bear with me here just a second, but this is going to give everyone time to ask some questions while I fumble around. And here I come. Okay. There I am. All right. So yeah, right now we just have Dr. Roth saying hello. All
Hello.
right, here we go. What length of time do you recommend immobilization after an acute ankle sprain?
Yeah, and I may come back and do that in another webinar. There's good evidence that strict immobilization for 3 to 7 days after a severe ankle sprain gives a better outcome. And I subscribe to that in my own experience as a clinician. There's nothing wrong with putting these patients initially in a walking boot and protecting them totally for 3 to 7 days, but not anything longer than that. Beyond that, you must start weight bearing and start protected ambulation with the protection of an ankle brace. Even it could be an off-the-shelf ankle brace that allows sagittal plane motion but restricts inversion, eversion. And you must start passive and active range of motion exercises with a therapist and at home to begin stimulating those proprioceptors. That must begin within 7 days after the sprain.
Well, now I can't see. I was getting a glare off of my glasses, but I'm blind. Okay. I see a lot of runners with tibial varum deformity. How do I brace appropriately in this patient population? Same for orthotics.
Great question. Tibial varum presents a challenge when you brace the patient because most ankle braces, because you secure it around the ankle or the distal leg, they tend to hold the foot in alignment to the leg. If the leg has a varus deformity, the ankle brace will hold the foot in varus. And that ankle brace can become a problem creating a bigger problem than it would be without it. With the Richie brace, we asked the clinicians to document tibial alignment. If there's tibial varum of 5 degrees or more, we bend the ankle brace. We bend the foot plate away from the limb uprights to reach the ground. In other words, we compensate for the tibial varum so that the foot is now flat on the floor. If we don't do that, that foot plate is going to align to the leg. And if the leg is inverted, the foot plate's going to be inverted, and we've got a problem. So I think that's a great question. It's really important to recognize tibial varum in athletes that you're going to brace, and you must do some compensation in the foot portion of the brace to evert the foot to the leg. Otherwise, the brace is going to invert the foot.
Okay. When sending a casting or an image on the Richie brace, would it be beneficial to do a separate orthotic casting, or will the iPad scan be enough?
No, the scan will capture the foot and the leg, and it should if it's done properly. And you do not have to do a separate scan of the foot. We require the scan to capture the plantar surface of the foot, the medial and lateral aspects of the ankle, and the distal 1/3 of the leg. And that's easy to do if the patient is placed in a prone position on the table. We've got a whole webinar we did on casting and scanning for the Richie brace, which you can access on the Richie brace website. We have a tab called Education that shows videos for scanning and casting, and it shows the webinar that we did on casting and scanning. So I'm glad you asked that question.
Yep, that's richiebrace.com/webinars. So it's pretty easy to find. Okay. Can you provide a written protocol for ankle sprains?
You know, the best written protocol, I used to provide one, but when I saw this one from Rob Roy Martin, I realized these guys are just way ahead of anything that I've done. So I put that, I'm going to show you this real quick, but I would write down this reference and follow it. I mean, this is like a 15-page paper, and it has not only the protocols for rehab, but it has all the decision-making for returning the athlete to play, which is a whole topic in itself. And so I think this is a good reference for you.
Awesome. That's handy. Maybe we'll put that up on the website.
Sure.
Let's see. Do you see neuroplasticity/brain changes after the very first sprain? If yes, what do you specifically write for in your physical therapy prescription, and how do you help the young patient/athlete? What is your post-sprain protocol?
Okay, great question. The first question, almost every one of those papers that I showed, that I presented with neuroplasticity, were on chronic ankle instability. However, there's several papers after anterior cruciate ligament sprain, a one-time injury, where neuroplasticity takes a hold. Because we've asked the logical question, was the neuroplasticity there before the sprain? I mean, did it actually create the sprain rather than vice versa? Most of the experts in this field think it's the sprain triggers neuroplasticity. And we're pretty confident that the first-time ankle sprain absolutely creates neuroplasticity. It's just most of the studies are done on chronic ankle instability patients. When it comes to the child or the adolescent with a first-time ankle sprain, the protocol is the same as what you see in this paper I have up on the screen. The young athlete who sprains their ankle, they probably are going to heal faster than the adult, but a ligament is a ligament. And they should not return to sport with a grade 2 or grade 3 ankle sprain for at least 8 weeks. And when they do return to sport, they better wear an ankle brace for at least a year. They should be put through supervised rehabilitation, just like an adult. I think that's one of the problems with kids, is for some reason we don't think of sending kids to physical therapy. We don't think of putting kids into balance training and strength training like we do adults, but they need the same rehab that adults do, probably more. And so I think the problem with kids is we don't rehab them like we do adults, and we certainly return them to sport way too early because of peer pressure, pressure of coaches, and really due to the ego of the parents themselves.
I love sports parents. Grew up with
Oh,
a lot
yeah.
of those. Yeah, they're the best. Okay, during protective weight bearing, would you use a tall boot or a short, like a high top?
I would, great question. A high top boot is useless. I'm sorry, a short top boot is useless. A short top boot allows 20 degrees of ankle joint dorsiflexion. You might as well use no boot at all. You must use a full length boot, but only for 7 days. But but the boot allows the patient to bear full weight safely. I do not believe in using crutches after an ankle sprain. There's definite benefit to loading the ankle with weight bearing in a boot, because when you put them in a boot and load the ankle, you stimulate muscle activity right away, which is advantageous, and you push that talus up into dorsiflexion. So all that's really good. But after about 7 days, the lack of sagittal plane motion in the boot begins to work negatively. And you really need to move them into a hinged ankle brace, an off-the-shelf hinged ankle brace. There are many inexpensive hinged ankle braces with foot plates on the market. We have one. It's called the Richie OTC brace. Oser has one called the Rebounder. The Active Ankle is an example of a foot plate ankle brace. An air cast brace is not sufficient because it only is a stirrup around the malleoli. It does not control the foot plate. It does not control the foot itself. So the intermediary brace would be an off-the-shelf foot plate articulated ankle brace, which can be purchased for under $50 and should be worn for 6 to 8 weeks after the initial ankle sprain.
All right. That's our last question right now. I'm just laughing at myself because I have chronic ankle instability, and I am embarrassed about because I grew up playing competitive tennis, and all of my bodily injuries are never because of like playing the sport itself. It's from like stepping on the ball. That's the dumbest reasons. It's so embarrassing. Oh, good, we've got another one that came in. How do you modify your protocol for a high ankle sprain?
Yeah, that's a great question. The high ankle sprain is a totally different animal. It does require long-term immobilization, much longer than the inversion sprain. And the ankle should be kept dorsiflexed. And the problem with the high ankle sprain is that it's the opposite. It's internal rotation of the tibia and it's external rotation of the foot. And there's not a lot of ankle braces that hold the foot properly. That's really a big selling point for the Richie brace because it's got a 35 millimeter heel cup and it really controls that transverse plane motion of the foot. But the high ankle sprain, those syndesmotic ligaments, they don't do well when you allow a lot of ankle motion. They really, you really need to keep that ankle fairly dorsiflexed and immobile in a boot for up to 4 weeks. And removing the boot off weight bearing for non-weight bearing range of motion, but we're not as aggressive in returning them to protected weight bearing as we are with a lateral ankle sprain. And so the high ankle sprain is really problematic in terms of the long-term recovery and the need for long-term immobilization. Now, I will tell you that most of the research I showed you in terms of neuroplasticity is with the classic lateral ankle sprain, the so-called, the minor inversion sprain, not the high ankle sprain. That's not to say high ankle sprains don't cause neuroplasticity, but the focus of this particular lecture was really on the lateral ankle sprain.
Okay. We got a couple more questions that came in, but as you're answering these, if everybody can take just a quick minute to chime in on the chat or on the Q&A and tell us, like Dr. Richie mentioned at the beginning of the webinar before the presentation, if you can let us know what you'd like to see from Dr. Richie in the next couple of months in terms of presentations and topic. I just dawned on me because the next question is, can you review billing and coding? And I don't know if that means now or later, but you can give any sort of short response now, and then maybe we can do a full webinar later. So, but if billing and coding is something you'd like Dr. Richie to speak on in the future, because we are going to do these about every other month, let us know. And whatever other topic suits your fancy, just type it in so we can take a record of it. And then Dr. Richie will get to choose.
Yeah, I think they were asking if we could do that as a topic, which we've done before, and I'm happy to do it again. But it's funny, Sarah, I was thinking about this. What if I get a question about billing and coding tonight? And there is something important to keep in mind here. And that is with Medicare, this is really tricky using multiple ankle braces, which, by the way, I'm advocating at least 2 braces for the patient, a walking boot in the first 7 days, and then an ankle brace after that. If it's a Medicare patient, you've got a problem because that's a same and similar instance where if you dispense a walking boot, Medicare is not going to pay for any subsequent brace for that patient. Now, I'm quickly going to say, I don't treat a lot of ankle sprains on Medicare patients, so happily, this is not a dilemma in most patients who suffer ankle sprains. But if it is a Medicare patient, you've got a problem. And if you're pretty sure this patient's going to go on and need a long-term Richie brace, my advice is to charge them cash for the walking boot because walking boots are affordable. And their price pales in comparison to a Richie brace. And Medicare is only going to pay for one or the other. So make sure you bill Medicare for the more expensive brace, but you're not going to get paid for both of them. And you're going to have the patient opt out and sign a form, which I'll go over with you in a follow-up lecture. But they're going to have to opt out of Medicare and pay cash for that walking boot.
Yeah, I was gonna say, it's like, that's when we go to cash.
Yeah, yeah.
Yep. And I think, there's, you just can't be afraid of saying it. You just can't be afraid of asking for cash.
Yes.
It's a big hindrance in a lot of practices. So it's ripping off that cash band-aid, I think. So we have a final question here regarding the articles. Are you able to share the articles? And I don't know, Dr. Richie, if you're able to share the entire PDF, but I'm happy to go through and create a listing for everybody to access, and I can send a follow-up email. What are your thoughts?
Yeah, so I think we should post a PDF of this webinar. And that PDF, you can, like this slide here, you can print it and look at the citation, and then you can try to get the article. If you really want that article and you reach out to me personally, I'll share it with you. I cannot post it on our website because I'm going to violate copyright laws. But I have all these articles, and if you personally reach out to me, I'll share it with you. And so my email is on the Richie Brace website, but Sarah can post that too. I think I'll just stop
I
sharing.
think, and it's on your, it's on a slide 4. It's the yellow slide that
Yeah.
kind of.
Okay. So my email, my contact info is on this webinar slideshow, and you're also going to get a PDF version. So just send me an email and tell me specifically which article, and I'm happy to share it.
That's awesome. Cool. Well, 200 slides. You did a great job.
No, I skipped a bunch, but that's okay.
Okay. I was going to
Yeah.
say, that's the magic trick that I didn't see coming.
Okay.
Well, thank you so much, Dr. Richie, and thank you so much for everybody who joined us this evening. Again, this is the launch of Embrace, AFO therapy, and hopefully you get the play on the word play there, but try to be as clever as we can. So the Embrace AFO Therapy webinar series, and would love to hear from you and know more about the topics that you want to see in the future. Otherwise, we're just going to choose for you. So this is your time to be heard. So thanks again, and I wish everyone a fantastic week. Dr. Richie, is there anything else you wanted to close out with before we sign off?
No, except everybody, I hope you enjoy March Madness. This is a fun time of year.